Hi, everyone. This is the Cancer Patient Lab. I'm Brad Power. And before we get started with Ari Akerstein telling his story, the rogue patient, and how he's solved his own problems and wants to bring it to other people, uh, we will do a quick bit of housekeeping. We have three standard parts to the housekeeping. The first is this is not medical advice. This is information that you can take to your medical team to help you in making decisions. Second, this is everything here today is going to be made public. So if you're concerned about that, you can cover your video image, change your name, and not say anything. And the third is the Cancer Patient Lab is a patient-led community of all volunteers, and we would appreciate any donations that you might make, which you can do through our website. With that, I will turn the controls over to Ari, but I'll just do a quick intro. Ari and I were introduced by a mutual friend, an innovative doctor, and I learned that he is a lymphoma survivor, as I am, as he will explain. So like many of us, a cancer survivor, and has witnessed the problems in the way that patients experience our healthcare system firsthand, intensely, and is also by background a product manager from Silicon Valley, so has the Silicon Valley software perspective on developing apps and entrepreneurship. And so he's sort of combined those two things to talk about some ideas that might be useful to people. And we've been collaborating to develop this notion, both for him and his startup ideas, as well as the idea of creating an accelerator of like-minded founders who have similar needs. So he'll go through all that, but I just wanted to set the stage that way and turn it over to Ari. Thank you.
Thank you. Thanks for the intro, Brad. And let me just start off by saying it's really nice to see you all. Alan, I know we're on many threads, so good to put a face to a name. And it's a little bit, I hope this will be useful to this group. From the few sessions I've sat in on, this is really like the top 1% group of patient citizen scientists. I've just been nothing but impressed. And so a little bit intimidating to be here, but a privilege nonetheless. Let me share my screen, see if I can do this. And I want to keep this fairly, all right. Is that working for you all? Okay, great.
Yes.
Awesome. I want to keep this fairly informal in the sense that if you have questions or areas you want to go deeper on, please feel free to jump in. I don't, it's not a wait to the end kind of thing. I want to make sure that this is as valuable as it possibly can be to this group. And so the things that I'll talk about, really what I want to do is go through my own personal journey, how I got here, some of the lessons that I experienced, and some of the approaches that I took in dealing with my own large B-cell lymphoma, which probably, well, I don't want to make assumptions, but it's an aggressive blood cancer. It's when you ask the question, what's the do nothing case? It's 6 to 12 months, very, very aggressive situation. And so I'll talk about some of the lessons and approaches that I took that worked for me. I hope that you find them useful, and also very open to hearing about your approaches and if they diverge from the things that I've done. And then, as Brad alluded to, we'll talk a little bit about the accelerator that Brad and I are kicking off. We're in the initial stages, and so we'll give a little primer on that. Always dangerous to start with a quote because it's probably Mark Twain or Lincoln or somebody. In this case, it's Churchill, apparently, but I definitely believe in this one. The context for me was I had just turned 40, was a new dad, living in San Francisco, was working in Silicon Valley at places like Walmart Labs and Facebook and startups and doing that whole thing. And really, this was a lead up of me feeling some kind of small thing in my abdomen, not knowing very much. I thought it was, can can things get trapped in your intestines? Like, what the heck is this? And was avoiding going to the doctor, thinking it was nothing. And then my wife um, probably saved me by saying, "You're being a very typical guy. You should go and swallow your ego and go get it checked out." And I did. And after a month or so of tests, it was very. I got some hard news, which is you have gobbledygook. I'm like, I don't know how to make sense of even what you're saying. But I went from very healthy to uh, where am I very quickly. And so I remember very distinctly, I was biking to work in San Francisco and sat down in a coffee shop. And I was just in utter disbelief, shock, not really understanding like what was up and what was down. Um, and from a chronological standpoint, I got this test result that I did not understand from my PCP, which just goes to show how naive I was. I didn't even know the words that he was telling me: non-Hodgkin's lymphoma, B cell diffuse, blah, blah, blah. Um, and I'm like, so that means cancer? Like, what, like, what is this that you're talking about? Um, and I was expecting a call from the oncologist to help orient me to figure it out. Like, PCP hangs up. Okay, you'll have a call in 5 minutes from the oncologist. Instead, I get a call from a nurse navigator, which I don't know what a nurse navigator is, from Kaiser, which is where I was going. And she she literally launches into, let's schedule your chemotherapy session, and a bunch of other logistical matters when I don't even know what's going on. And I very very abruptly tell her that it's time that you hang up this call and you get the oncologist or whoever it is to give me a call and help me sort out where I even am. But this is not appropriate to like start jumping into treatment scheduling. Like, this is ridiculous. So this was my nurse navigator who was supposed to help me with this. What I ended up doing was I created what I call the oh shit list, not the shit list, but the oh shit list, which is um, called up the CEO at my company who I was working for, and I'm like, hey, I don't know what's going on here, but I'm not coming in. Called my wife, said, I don't know what's going on, but I have some bad news that I have to sort out. And then I wrote down a list of like 5 or 6 people that fit a very specific set of constraints, which was they're rational, they're like not super emotional, and their emotional valence tends to be positive. And I felt like that was what I needed. And it was very clear that this was a much bigger thing than me, and I needed to process with some friends. And thank God I had some that fit that criteria. And I spent the next probably 2 hours, which is literally 2 hours that I'm waiting for this oncologist to call. I thought it was going to be a few minutes, which is what the nurse told me. Made those calls and sort of brought my shock levels down from, whatever, 100 to 80 or something. And it became clear to me also that like I was going to be fighting this system, like just from that very first entry point, I'm going to be fighting this system. Like, this won't be easy. A little bit of background for me is some of the like approach that I had mentally around this was, look, you have biological systems. Like, I studied biology and molecular biology, so I knew enough to know about how much we don't know, and that systems they're always broken and fallible. I saw this firsthand with my own family, and so I had this kind of at least initial awareness that things don't go well often, particularly if you're unprepared. And so part of the way that I thought about this was I saw family members who were not very vigilant or questioning dealing with the system, and I saw how that produced really poor outcomes for them. And so my attitude going in was very much like, hey, life is a lottery. I was actually fairly okay with like, if this is my time and this is what it is, like life is a gift. Okay. And if it's going to go that way, fine. The thing I could not accept though was that some idiotic human decision or fallibility or poor system design was the thing that was going to do me in. And so I took that really to heart. I noticed that I was having a lot of phone calls, and that was not going to scale with respect to keeping people updated about what was happening. And so one of the first decisions that I made was I sent out an email to like my network, everybody I know. And that's a really uncomfortable thing. I don't know about you. For me, that was like, wow, this is really uncomfortable to send out something like this. I kind of forced myself to do it. Um, and this is probably one of the more high leverage emails that I had ever sent out. And I mean, right off the bat, I got friends started like they generated like $10,000 GoFundMe, like to just deal with life and my family. And that was like just out of the blue, like crazy to see that energy. Um, Advice, connections, and friendship. I got food delivered to my house, like more than I could eat. And it really turned into like a large embrace from people that I hadn't heard from in a very long time. I think my tendency, which I was fighting, was to kind of go it alone and maybe like do this on my own or a little bit in a lower key way. And I'm really glad that I ended up doing this because that kind of set the trajectory for a lot of the things that ended up happening. I also realized that I was doing email updates, and those email updates also wouldn't scale. And so I ended up starting a blog really just to keep people kind of updated, very utilitarian communication kind of thing. Um, and that ended up taking a life of its own, where I found that it ended up being therapeutic for me. I would get up at 5:30 in the morning and just write because I had so much on my mind, you know, from emotional to like, what the hell did the doctor just say? I don't even understand it. And it really helped me process my own thoughts. But the second order effects of this was that it really helped activate other people to help me in a time of need. And that was incredibly useful. Um, and it helped me think through like a lot of hard decisions that I'll talk about in a little bit. Um, and I realized also that it ended up growing in a way that I did not expect beyond the utilitarian communications. Like RBG wrote me a note, and it was just like, wow, the amount of goodness coming back is just crazy. And so that was quite amazing to me, and also just motivating to get a little bit of like nuggets of goodness coming from the universe. I also focused on the mental game quite a lot, and I like to think of it as focus your focus. Um, I like Stephen Jay Gould, and I thought that this fit my anecdotal perceptions, which is that this quote. I won't read stuff you all can read well. But like your attitude really matters a lot. And there's enough anecdotal, like I don't know mechanistically how it works. Does it impact your immune system? But there's enough anecdotal evidence suggesting that a positive attitude is better than a negative attitude. And so I tried to be clear with myself about where I would focus my sort of low resources and energy on making smart decisions, being as present as I possibly could, which for me is not easy. I'm like a person who lives in his head quite a lot and you know, won't notice things around me. And so I really tried to be present as much as I could because I knew I had to have a clear head to kind of go from emotional to putting on Spock hat and making decisions, which I really did need to do quite a lot throughout this journey. Um, and tamp down on the anxiety that I felt like I was feeling. What this all says is what I was not focused on, which is what I would have been focused on, which is thinking about the outcomes. How is this thing going to go on the end of it? Things that are not inside my perimeter of control. And so I really thought about how can I step inside the perimeter of what I do control and not focus on those outcomes because I do not control them. All I control is the inputs going into the decisions that will lead to outcomes. Um, I felt like that was very important. Also, I see some chats. I'm not opening up the chat, so feel free to jump in if there's anything kind of relevant to what I'm talking about. I also felt like it was important to be deliberate about deciding how I will decide and how I will approach the myriad decisions that I will need to make or probably will need to make, not knowing really kind of the fog that I'm stepping into. I drew out this napkin sketch and I ended up going back to it quite a lot. And it helped me, and I'll talk about a little bit more about how it helped me later. But I think just having a intentional framework about how one will go through decisions is really important, particularly when they pertain to your health and your life potentially. They carry incredible amounts of leverage. And so in a way, I felt the burden of ownership for caring for my own health. And uh, in a way, it was a little bit like what I do at work, kind of day to day. But in terms of kind of the formula that I was traversing in making decisions, it was like, okay, what's the timeline that I have? For example, from my diagnosis to jumping into chemotherapy, I had 2 weeks. They're like literally not more than 2 weeks. So I was like, okay, then I have 2 weeks and I'll uh, do what I need to do inside of that. The way I think about it is kind of saturating the amount of information that I get inside of that amount of space, which is kind of the dotted line here. You're not going to get 100% perfect. Don't aspire to it. Just get as much as you possibly can. And so this kind of, you probably can't read my scroll, but like after a while, you get diminishing returns on the amount of information that's useful that you'll actually get. Um, and then make a decision and move on and be good with it. Um, Related to decision making, this was another way that I thought about this, which is that um, Jeff Bezos has a really great way that he likes to describe decision making, which is one way and two-way doors. Maybe you've heard this, and he writes about it in his letters sometimes. And so the two-way doors are reversible decisions, and so you can make those quickly. There's really not a lot of penalty in making the wrong choice. However, for medical decisions, I feel like the leverage is so high. And as I mentioned at the beginning, I saw this go down really not great paths for my family. And like, for example, my grandfather died from, just like an error. My father had to retire early, young, as an engineer and like had all these issues coming from it. And so I think of all these as non-reversible decisions. And so the other thing is when you are not a domain expert, which I certainly was not in cancer, I felt like I needed to triangulate. And so I kind of constructed this imaginary pyramid, if you will, where at the top I had my oncologist and kind of the very, very super specialized expert. Um, at the bottom, I had groups of friends that I trust their judgment because they deal with just uncertainty all the time. Maybe they don't know anything about healthcare or whatever, but they make a lot of decisions under uncertainty and have a track record of doing that well. And then in the middle, what I call adjacent experts is people that are maybe less clinically oriented, but have understanding about molecular biology, mechanics of how some of these things work. We were talking about TNF before, or, tell me about P53 or whatever. Help me understand some of the things that are related, maybe at the more foundational research level, but maybe not a clinical expert. And so gaining a window into how the landscape of what's possible may be evolving. Like, is there a new treatment coming down the pipes in the next year that my doctor wouldn't tell me about, that sort of thing. And so kind of fewer to most from the top of the pyramid to the bottom. I found myself really leaning on the smart generalist quite a lot to help me out with decisions. The other thing that I noticed myself dealing with wasn't specifically medical decisions per se, but kind of setting the conditions for the battle that I was going to go into. So I remember doing this even before starting treatment, which was, okay, what's a regretful kind of place to wind up, and like what's the not acceptable outcome? Because it could be that nothing works and I die, right? So how do I minimize regret, so to speak, on this? And so I kind of drew out a little tree for myself about whether I was going to work. I mean, that was the first question. Like, should I work or should I quit and deal with this? Or not quit, but go on disability and kind of put everything on life on hold and just deal with this. And I don't know if y'all can read this, but it was basically like the same odds of the treatment being successful or not, because like, I don't know what impact working or not would actually have. And I don't know how to change those odds related to that. What I did notice, however, was that if you look at the treatment not successful, 10%, let's just say, I was making up these numbers a bit, but if I worked and the treatment was not successful, I knew I would have regret and I would have these what ifs, and maybe I shouldn't have, and maybe it was stress and maybe this and maybe that. And I felt like that wasn't going to be acceptable to me. So this was very useful for me to actually simulate the outcomes, not just kind of numbers, but actually like gut check it with myself to see whether um, how these decisions actually played out in the various scenarios. And I found this useful, and this helped me decide to not work and like never mind the money. I just can't deal with like not knowing whether the stress of work, which I was a little bit stressed at work, had contributed to that outcome. Um, are we good? Any like questions? Anything so far? I
Ari,
saw a
I
few
just,
chats going in.
I don't know what your schedule is on this, but I just want to encourage you to kind of do a short version because we like to leave plenty of time for discussion.
Awesome. Uh, some of the things that I additionally needed to do was to um, deal with hard things that were unexpected. So I don't know if any of you do self-injections. I was using, I think, Zarcio for neutropenia. Um, and I could not get over that. And I really needed to call a few friends and kind of uh, like hack my psyche in a way. I could not do it. I literally could not do it. And it took me days to be able to actually like puncture the skin. It was really embarrassing and ridiculous. But when I got on the other side of that through a lot of help, here I'm like with my brother, and I called over a nurse to help me, and like I couldn't do it myself. But every time it felt like a win on the other side of it when I could do it. So that felt like progress. Another thing was I was terrified of chemo, and my mental model was really like I had seen Breaking Bad like that show Breaking Bad, and that was like what I thought of chemo. I really didn't have a reference point because nobody really in my family had dealt with this. And so I decided to flip the script and make this into basically it was 6 rounds of R-CHOP, which is a chemotherapy that I was prescribed with 3-week intervals. And so I tried to make every round into a memorable event. And so I would invite some friends and colleagues and people like that. And what would have been a really hard and isolating event for me ended up turning into like a really great set of memories. And I found that really useful and motivating for myself. And I think my friends got value out of it as well, and seeing the other side of it and kind of getting a window into what that process looks like. Um, okay, so I went through 6 rounds. This is, sorry, a little bit of, a little bit out of order. I apologize. I went through 6 rounds of R-CHOP, and for those of you who may be familiar, maybe Brad, you are, but if you fail the first line treatment for diffuse large B cell, that's really bad, and your odds start like dropping very quickly on a curative um, treatment. And so bedside manner was not my primary oncologist strong suit. I mean, he literally is like, I have devastating news for you. And I dropped my phone and just like no bedside manner. But what happened was the CT or the PET scan showed residual activity, which is very bad. And then I apologize. This actually did come first. So there was residual activity. I needed to get a biopsy. I thought of a biopsy as just like a little needle thing and, in and out, outpatient. It turned out that the cancer was growing behind the bowels on something called the mesentery, I think it is. And that's a pretty dangerous spot for actually doing a surgical procedure. So I talked with the surgeon. I had no idea how to actually assess whether a surgeon is good or not. Maybe you've had this challenge, but how do you know? Like there isn't like a rating scale out there. And so ended up doing some maybe underhanded things and asking the front desk person, well, who's the pest doctor? Who do the doctors send their family to? And that sort of thing. And ended up talking to a surgeon who originally, the first surgeon wanted to he literally said, I'm going to slice you open like a fish and go in the old fashioned way, which scared me. And also I have a wife and 3 kids who are very young, and I felt like I'm going to be useless for the next 6 weeks. So I tried to see if I could change that, asking just a bunch of naive questions, which I specialize in, which is, like, well, could you do this laparoscopically, like, with like less damage? No, can't do it. I call up a friend whose wife is a surgeon. Is it possible to do a thing like this laparoscopically? Yeah, but you need some skill. Anyway, and it ended up doing a negotiation with another surgeon and got a three-way call with my friend's wife, and we worked out. Um, Basically, I built this model and then worked out like uh, an alternative path, got checked that it was reasonable, which is, could you start laparoscopically and then abandon if you get in, if you feel like it's tough to actually get the tissue. And I felt confident enough that this would be a better path, which is the laparoscopic with open kind of option, that would be like a better way to go overall in terms of biasing on safety, tissue sample, recovery, pain, that kind of thing. And the surgeon agreed in the end. What I showed here was sort of my triumph, which was not a gigantic slice down the middle, but just a couple of stab wounds. And that really actually was helpful, not only for me for the recovery, but because I could help my wife with like kids for 6 weeks, which would have been just, yet more burden. Um, this was a, I will actually talk to this in a follow-on slide, but the one of the keys was that to the direction that this actually went was that I got a pathology report and I shopped around the pathology report that came as a result from the tissue collected in that biopsy. And there was, I remember my Dana-Farber second opinion told me that she wasn't convinced by the pathology report. The verbiage was kind of suspect. It was hand wavy. It was not very convincing one way or the other. And uh, and I got similar signal when I actually shopped this around back to the triangle, kind of the middle tier, talking with uh, people who know something about these pathology reports, staining approaches, things like this. I just screenshot from Israel where I sent to a friend of mine who was a doctor there working on some on cancer. And got enough doubt about the pathology report to request that the surgeon take a additional sample and store it because I want to run a second opinion on the pathology report. Um, as a result of that, I was left in a bit of a conundrum, which was that I had a bunch of scenarios with the activity from the CT and the PET scan showing residual activity. R-CHOP failed, first line had failed. Now I need to take some action. And that left me in a weird space where I had Kaiser, who I didn't fully trust for quite a few reasons, telling me that I should do a low probability second line chemotherapy or an autologous stem cell transplant. This was a few years ago where CAR T was just starting out. And so I could potentially get onto a CAR T through a clinical trial. And so this left me in I have no idea what the right approach to take here is. I don't really trust Kaiser. I have a few other second opinions through UCSF and Dana-Farber. But what I did in going through this golden triangle approach was I was talking with many of the smart generalists and kind of that middle tier, and realized that speed from getting CAR T, which brings with it a set of risks, assuming I could get into the clinical trial, brings a set of risks like cytokine storm and other things that were still a bit earlier, depending on which version of the CAR T. There were like 3 of them, which is just yet more complexity. And so what was useful, though, was to put side by side the CAR T in a clinical trial, assuming I could get onto the trial arm of the clinical trial, which is like a blind thing. And so you don't really control that, but you would enter anyway with the chance of doing that versus the stem cell transplant. And so what I ended up doing really was going through kind of the probability tree, like to poke holes in my own understanding and be able to socialize this with friends. And so I remember having a bunch of conversations with CEOs and other people like this that were really good at the decision making under uncertainty. And what was fascinating was seeing a convergence on the speed of learning as the most important thing for me to get. Whereas stem cell transplant would take months, CAR T, I would know fairly quickly whether it was effective or not. And seeing that convergence of opinion um, from, let's call it smart lay people was really validating to go down this path. Um, and so I kind of buried the lead a little bit here, but in making that decision, I then had a meeting with Stanford. And from those three options, none of which were appealing, actually, they were all scary as hell. I remember bringing my daughter into Stanford, and this is the head of the hematology lab. It was amazing. And he literally pulled up my new pathology report that he had run in order to verify my eligibility for the stem cell, or rather for the clinical trial, and said, "You have a beautiful daughter. let's let's do nothing and let's just wait and scan you again in 3 months." And the result was complete remission. Like, don't do anything. And it was, I mean, it was remarkable because I had spent the last like 3 weeks really like agonizing over what to actually do here. Some of the keys for me when I reflected on this was that, like, I mean, getting a second opinion is mandatory, but I mean, in my case, it was a third and a fourth opinion, and it was the fourth that actually dissented and had me not doing anything except watch and wait, and and convincing me that I wouldn't die if that happened, which was also divergent from what Kaiser had led me to believe. Which is just shocking. Uh, Using a deliberate decision-making process for me was just, I mean, it sounds almost corny when I say it, but that really was essential to take the amount of time that I needed to learn as much as I could in the allotted time and not jump right into getting it done and doing what the doctor said was absolutely essential. Getting the new data. So doing that second pathology report specifically at Stanford. Um, Incidentally, they had invented the staining technique that was being used by Kaiser, and so they felt like they had more confidence in their ability to interpret those types of reports than Kaiser did. And triangulating those opinions with my network, let's say, was really useful as well. Um, and yeah, lucky bounces definitely follow the prepared mind. So I'll stop there with that part of it before jumping into um, some of the work that Brad and I are doing. But any questions or anything to dwell on there before moving on?
Hey, can I ask a question? Just to make sure I'm clear. So did you have a spontaneous remission? Was there anything you were doing?
Uh, I did a whole lot of other things that impossible to attribute, like uh, I mean, doing a pescatarian diet and drinking green tea and working out. Like, I have no way to know whether those things were useful or not. In fact, I had a slide with all those things and I just deleted it because it's too anecdotal for me. I think it was useful, but who the hell knows? And I have no evidence from it. What I think it was, there's small evidence that you could have spontaneous remission. When I read the papers, it was in the sub 5% on that. So I don't know. I think the likelier situation is that they may be tested early and there was residual activity from the chemotherapy drugs, maybe lingering and killing certain populations, because it's not a homogeneous population necessarily of these types of diffuse large B cells, as I understand it, but you could have follicular indolent type of cells mixed in, and maybe the composition of cell types changed. It could be the pathology misinterpretation. It could
That
be,
was the second thing I was going to ask you about. You said there was some difference of opinion over that
yeah,
pathology report.
yeah. The challenge is that I had two pathology, let's say, opinions. So the first one run by Kaiser, and then everybody at UCSF, by everybody, I mean UCSF, Kaiser, and Dana-Farber, all were reading that same they weren't running their own pathologies. They were taking the pathology report generated by Kaiser, and using that as the data to kind of ascertain the truth and what the treatment, path ought to be. So the tip off was that Dana Farber, my doc there, Karen Jacobson, who's fantastic, if any of you know her, she thought the verbiage, she wasn't actually looking at like the staining technique itself. She thought the verbiage around the description of what was going on suggested a second-rate pathologist. It kind of like in passing, it was just like a thing that like my eyebrows perked up a little bit when she said that. And I was like, huh, do you maybe not trust this? Maybe I should get a second pathology. And she's like, yeah, it wouldn't hurt. Okay, just go for it. And that was quite telling, I thought. So there was that. Oh, I'm sorry. Is somebody saying something?
Go good. I got one last question. Sorry to interrupt, but
yeah,
that last slide of yours really kind of caught me. These lifestyle changes you made, the pescatarian diet, the exercise, etc. Is that change? Is that way different than what you were doing before?
It was much more intentional. Gosh, I wish I didn't delete that slide. It was kind of long.
I wish you hadn't either.
I can. You know what? I'll tell you what. After we go through this, I'll see if I have it in another deck. I could probably pull it up and share it with you. But it was everything from. I basically had like two or three buckets. I think I had mental, physical, nutrition. I think were like the three buckets, and then there were like, a dozen in each one or something. But again, this is a tangent a little bit, but it is fascinating to whenever you have advice that is sort of 180 degrees opposite from one another, that should make you like tingle like really hard. Like, should I be a carnivore and just eating only meat for inflammation, or should I be like a vegan Ayurvedic? It's like these two things are not the same. So that just should make you like suspect of like any of this. But I'm like, well, green tea, if I steep my green tea for more than 10 minutes for the ECGGC or whatever the acronym is release, it looks like no harm, no foul, although the evidence is pretty scant from when I read it. So I'm like, well, all right, I'll do it. It's not going to hurt anything. And maybe there's a placebo effect, which, to be honest, if there's anything I could point to, it's probably that like all these things are summing to some kind of placebo effect, which is known to have some weight. But I'll share it with you for sure, Roger.
Thank you.
Absolutely. Did you draw any conclusions? Well, I was going to repeat Rick Davis's things for the question, but he's raised his hand. Rick, go ahead and ask your questions.
Yeah, hi, Ari. I think that one thing that can be taken from this session for anybody who listens in the future is to be really leery of Kaiser. You say KFF, I think you mean Kaiser Permanente.
Kaiser, yeah, Ari. I'm sorry, Kaiser is acronym.
Right.
Family Foundation.
Kaiser, I personally have a lot of experience with Kaiser. I was very fortunate that at the time that I was diagnosed, they had a contract with UCSF. So I got a lot of my treatment at UCSF, and I made some lifelong contacts in doing that. But Kaiser Permanente is a great system. It's flexible. It covers a lot, but it only covers to a community standard of practice. Now, most of the guys who are most of the participants in this group are looking at bells and whistles that are way beyond community standard of care, and sometimes way beyond centers of excellence standard of care to get uncovered here, as Brian will attest. And it's too late when you get diagnosed with a serious disease to switch your insurance. But it is really important to think about when you're choosing Kaiser Permanente. I mean, it can be great for a lot of people. It can be easy to get referrals. You can switch doctors incredibly easily. But as Ari has found out, as I found out, and as many people we navigate find out, it is really hard to get anything beyond standard of care. So they give you that first line treatment, they push you onto a second line treatment, and then they're not interested. And then you have to fight and appeal and jump through hoops if you want anything more than that.
Yeah, I couldn't agree more. I also, I had a new family, was living in San Francisco. It was perfect for me. It was convenient. It was across the street. It had everything that we needed. And on my radar was not, you might get diagnosed with cancer.
Yeah.
So that's one. Two, they do actively, I would agree, and I think I would maybe say it more strongly that they actually did actively block excellent care despite their mantra that they provide excellent care or whatever it is when it comes to like I think they'll claim that they're providing like an academic center of excellence level of care versus say the community level of care as you described. And I felt actively blocked and sometimes even sabotaged where they were pushing the wrong narrative around why they would do something. So for example, I asked them whether CAR-T would be, possible or something, like you can say no, and that's fine, or we don't have a clinical trial here, or, the evidence isn't there yet. But to claim that the second line chemo in my case would be the better approach overall, when actually it came down to money, which is what it turned out it was just pretty underhanded, I felt.
Yeah.
So
And Ari, you're not alone. Don't feel they were picking on you. I mean, we've
I
seen
don't take it personally.
that's right. You shouldn't, because this is exactly how they operate. It is really, really, really difficult to get standard care. The only time I've seen them go out of their way is for some of their own very senior doctors, and even not so senior doctors who fall sick, and then you'll see them stretch. And we've
So
seen it.
I'll give you a tip if you ever are in this, because I had some dumb luck that got me out of there into Stanford, which was I was trying to push my way into Stanford by going through my primary oncologist. That proved unsuccessful because, again, he was pushing the narrative that they provide excellent care for my particular condition. What ended up happening, the way I got in, was my Dana-Farber doc this is the access thing, just as clearly as can be. She was former colleagues with the head of the heme lab, who was running the CAR-T study there. And she basically emailed him. She went silent when I was talking with her on the phone. I'm like, hey, are you still there? Yes, I'm emailing my former colleague over at Stanford. And what ended up happening was instead of me pushing, he pulled me in. He essentially kind of pulled rank on my oncologist and got me in.
Right.
So, sometimes you have to go the hard way instead of the easy way with them. Anyway,
Ari, I want to go up to a meta level a little bit based on a question from Alexander Lalov and I do mean that as a double entendre, which is, you are a unique person to be questioning the system and challenging the system and getting better outcomes for yourself. And the question is, who are you and why are you wired that way? And what was your background professionally? So you skipped over that a little bit. Could you give a little?
Yeah. It's not that interesting, but
no, but it sets up, I think, the why of
okay.
you were using problem solving techniques, et cetera, et cetera.
Yeah, okay. I skipped over it because I thought it was dull, but I have a weird background. I actually after college ended up starting a little fitness equipment company, making every possible mistake in the book. I just like to exercise. And despite myself ended up being successful, and that entailed everything from like bringing in doing the designs and doing user research, all the things that I ended up doing later in life as a product manager, which is I can explain what that is, but building products ultimately and delivering them to market in a commercially successful way. It's pretty scary when you spend your own dollar, and so I got used to that risk with like, oh God, I have to bring in a shipping container and spend all my money, and I have to bet it on, you know, like whatever this little website I built up, and the demand will be there and people will buy it and I'll have margin and all that. And so despite myself was able to make that work. Then went to grad school doing molecular biology and some math research, and then went to UCSF for a few years. And I was like, nah, this is not for me. I'm in Silicon Valley. Like I want to build stuff. I had a good insight into myself as a bench researcher, that I really like it, you know, maybe half of the week, and then I really don't like it because I like a mix of team and individual. So I think of it like a cross. I like to go deep and I like to go horizontal, is how I think about it. And because I was at UCSF, it was fairly easy to parlay a lot of those skills into just kind of the ecosystem that was around me, and then was off to the races doing like growth kind of roles, and then product manager roles, which if you don't know what that is, it's kind of like, think of a Venn diagram of like UX, like designers and engineers and business people, and you're kind of right in the middle where you get you know, all the accountability and none of the glory, but you do get to build things at scale. And so I've done that at some pretty big companies. Like I mentioned, I was at Facebook for a while, and Walmart Labs had a really large team there building out, you know, pretty big scale stuff, and also smaller companies. So I've seen it firsthand, you know, myself, and how to think about things and how to at least read some white papers. And so not being scared of the jargon, which I think was actually non-trivial for me, because, you know, there's a lot of jargon to cut through. And so I was comfortable with that. And so I think the combination of those things in the rearview mirror did allow me to question, challenge, think for myself from kind of the bottom up, or from first principles, as they say, about what was actually happening, combined with a distrust of the medical system. I mean, for God's sake, a lot of my friends are doctors, and I know how goofy they can be, and I love them, but, you know, like life and death, like you gotta triangulate. So what that actually points to, I forget who asked that. Was it
Alexander.
I apologize, Alexander. What it points to is another thing that I'd be remiss if I missed, which was when I mentioned the chemotherapy, and you're sitting there, it's kind of like sitting on the bus. It's a cross section of everybody. And the thing that was really top of mind for me was that I felt like I had a lot of access, and yet it was still so hard. Like, you know, maybe I have a little bit more willingness to go there and challenge and, you know, read papers, but nevertheless, the access gaps, like when I run the counterfactual and think about, if I had just done what my primary oncologist said, which is, I think, the majority case, like the base case, like, I mean, it would have just turned out really differently. And so I think that's a good also motivator on helping to fix some of these disparities. Like, you shouldn't have to go to these heroics and put this amount of effort in to get a decent outcome, or at least as good an outcome as you can. So long-winded answer, I apologize, but anything else before we move on?
Yeah, on that score, you've got 10 minutes, so I don't know how much more content, but try and bring us home. Cover everything you wanted to cover.
One slide, how about that? Crises are opportunities in disguise. I believe that too. Something that Brad alluded to this at the outset, is when we think about, you know, I drew a lot of lessons, and the question that I ask myself is, how can I be useful in helping to make some of this better? And I think, so I'm working on some ideas personally, kind of in, let's say, pre-stealth mode, as they like to say. But when I think about maximizing good, I do think that the notion of an incubator or an accelerator is a more scalable approach to actually helping to address some of the challenges in the market. Some of the reasons that I think this is true, and some of the like focal points that Brad and I have certainly been going deep on recently, include a focus on diagnostics as a key lever in the market in the just costs and outcomes space. I'm not going to read this slide, but the market trends are positive, they're growing, and I think there's a lot of supplementary trends or second order trends that will help fuel that. One of the big failures in the market that I've seen, I also have worked in like health tech, building telehealth kind of things and second opinion products as well. I guess just final bullet on that last question. And so I did see how that schism between building for patients, like now we're talking about tech, software kind of solutions, to deliver, almost like to deliver a Kaiser model, but not a brick and mortar, but a telehealth. What might that look like, except better? And some of the challenges there are pretty hard, particularly because you're not building for patients first and foremost. Everyone will tell you they are, but they're not. They're building for whoever pays you. And so I think the ability to work on closer to a consumer model where you can iterate and move high velocity and error correct, I think is really important. And so the focus is on enabling, basically building out an ecosystem with some of the network. And I think it's a good lead into like this group as well, potentially getting involved. But this group is, I mean, it's an astonishing group of people who are really taking their care sort of, bull by the horns and getting better than standard of care, as somebody mentioned earlier. Like, I think probably much better than what the standard of care, even the top level, would actually look like. So how do you enable a group of founders, builders to actually use technology and some of the innovations that are happening to deliver that in a more scalable fashion? I'll stop there. Brad, was there anything you wanted to add to that?
Yeah, I would give my own version of what you were just talking about, what we're trying to achieve with the accelerator. I'll just give a quick look at it, and then I'd like to cue Chris Apfel because he's right in the middle of the space that we're talking about. But and Brian is a monster for more data is always better. I mean, we were actually founded by Bryce Olson, who said "Mo data is mo beta," and Brian's like the most tested and analyzed person probably anywhere. And like, so what are the additional tests you can get? And then how do you decide? So it's an issue that wasn't an issue when you had immunohistochemistry and that was it, or immunohistochemistry but DNA sequencing. But now you can get a half a dozen tests, and the question is, which tests should you get? When should you get them? And how would you then integrate the information from all of them? Which is just a huge opportunity that you know doesn't I don't think anybody's really addressing. We had our session with Tony Magliacco, Protein Biodiagnostics. He's in that space. Chris is in that space. But we just see it as a huge opportunity or opening that needs help from a patient's point of view on navigation. Chris, do you have any comments on what either Ari or I have said, if you don't mind?
Well, I have a number of thoughts. First of all, I wanted to thank Ari for this wonderful presentation. I really enjoyed the decision trees and how you worked through there. And I would of course also would love to see how which kind of interventions have then supported your, I would like to say, spontaneous remission. In terms of your feelings with Kaiser, I can very well understand that, and I actually also think that as a whole, for a community healthcare provider, they are doing an outstanding job and are probably the most cost-effective and quality-oriented system that exists in the United States. So I think they're doing an outstanding job. But whenever you are having something that's really serious, it's really important. I did, and hopefully I am not too long-winded. What time is it? It's 9:57. What struck me is you said that informed and engaged patients have better outcomes. I feel the same. I'm an evidence-based data person, so I looked and searched the web and couldn't find support for that. I've just looked up a systematic review where it actually looked at the question of whether you actually have better outcomes when you are engaging in clinical trials. I've actually enrolled patients in clinical trials, and in clinical trials, you actually are under the strict supervision to really provide at least a standard of care. So you have much more supervision, much more diagnostics is going on, and you may actually be, if it's randomized, you may even be randomized to a more effective treatment that is on the horizon. So it was obvious to me. The meta-analysis or systematic review didn't come to that conclusion. I haven't had the opportunity to really research that. But what I recalled at some point in terms of differences in quality of care, which is actually interesting because when I'm getting asked by friends here, should I go to Stanford or should I go to PAMF and when I was up in Marin, the question was, well, I go to Marin County or to the Marin General Hospital, or should I go to Stanford? But now it's also Stanford. For large surgeries, it is already published, and I was about to download this paper, that there is large cancer centers, or there are other hospitals that leverage the branding of large cancer centers and create some strategic alliances, but the surgical outcomes for complex surgeries are inferior at peripheral hospitals compared to large cancer centers. And it has to do, so I'm an anesthesiologist and intensivist by training. It has also to do with, a lot has to do with standards and infrastructure. And just because Marin General Hospital is now also a UCSF hospital doesn't bring the quality up and the support system and the infrastructure to that level. That's number one. Number two, I actually also believe that that patient engagement is associated with better outcomes. There is an interesting website, blog, and book from Dr. Arkel Giorgio. The book is called Healthcare Choices, and her podcast is called Speak Up for Your Health. And what you there have is actually fits very well. So she interviews people for about 20 minutes and then comments on that. And the idea is really to encourage people to really speak up for your health. And you did this in a formidable way. What is and I do think you would be ideal for her podcast. What I found striking, and I'm actually thinking not only for the podcast, I actually think this should also be a publication. I would love to work with you on a project like that, because what's interesting is this 180 degrees different perspective depending on who you ask, and I think what I am a true believer that when people take the approach that Brad Power with his Cancer Patient Lab has basically built up this amazing community, I believe people have better outcome because they are better informed, and only if you are best informed you can make this decision. And I actually also believe that this is part of it, but it would be interesting how to put more substance to it. And that was going a little bit far astray from the question in terms of diagnostic and more data. I have more to say on that, but I don't want to.
I would love to follow up offline with you as well,
let's
Chris.
have an offline conversation. I've already used up 5 minutes on monologue here, so that was not my intention. I apologize.
That's okay. That's okay.
Yeah, as the moderator, let me just jump in here. We've reached the hour. We should stop, but we could either go over. We really haven't given folks much opportunity to comment.
I'm happy to stay if folks want to stay. I know we're out of time. Maybe stop the recording or whatever, but happy to hang around and talk with folks if useful.
Okay. So, and do you want to keep, and we'll keep the recording on, Ari? Should we do that?
You can also keep the recording on. I have to jump as well.
Okay. So let's just say we'll set a goal, another 15 minutes of discussion, and try it in respect for people's time. We'll stop then. Anybody who wants to raise questions, please raise your hand.
Thank you, Chris.
Call on you. Yeah.
Thank you.
Ari presented a lot. There's his own case, and then also this notion of an accelerator. Ari, maybe you go stop the share screen. Oh, we go.
Yeah.
Oh, we got it.
You know, I seeded it some questions for the group in case I didn't have enough to talk about, which seemed not to be the case, but you never know. So we could go into that, but let's prioritize whatever this group wants to talk about.
I have a comment about, again, it all fits in with some of the stuff that you're talking about, but one of the things that I've done is I've used ensemble reasoning to inform my choices for clinical trials and radiation and stuff like that. And basically, the idea of a tumor board, you go on and ask lots of people, lots of questions. Once you get something that comes back that makes sense to you, then you go on and act. That's sort of the approach that I've been taking. And that also fits in well with the points that have been brought up about, better informed people make better decisions for their own health care. And so the question comes up is, what is the mechanism that you should pick to become better informed? I basically use, I'm old, so I can go on and do a fair amount of Medicare to pay for my questions. And and that's my approach, but there are probably better approaches than that to have patients inform themselves about their care.
Yeah. I mean, that hits a nerve in terms of how much let's maybe frame it up like you can do it in a bespoke way, like you have good friends and you're part of the cancer patient lab. I think the other way is like, how do you do that in an automated way that produces access to a broader scale of people who may not have that level of education, interest, network, access even to centers of excellence, language barrier. I mean, there's all kind of blockers there. So I think there's like two parts. How do you do it on the bleeding edge to just push the standard of care as far as can be? And then how do you kind of bring up the base and give that to the broadest set of people in an automated kind of platform delivery fashion? I don't know the answer to either one. I have a few like intuitions, but it's a really good and hard question, I think.
I'll just make a note for you, Ari. You want to talk to Bill Passman. He's a rare kidney cancer survivor and an engineer, successful entrepreneur in Silicon Valley. So similar, kind of problem-solving background and culture from the Bay Area, and also cancer survivor. So you should follow up with him. Just looking at the raised hands, Alan Morris, you're up first.
Hi, Ari. So you guys, I'm going to characterize you, and you tell me if I'm wrong. You are big picture guys, and I learned this word. Believe it or not, I didn't even know this word. It's called process. Are you a process guy?
Not at all.
Oh, you aren't. So I don't
not even close.
That speaks to how the language, whatever you are, and what. Do you think what you're doing is something like what Brad's doing?
Say more. What Brad is doing in which way?
He's trying to solve the problem of cancer, and everything under that.
I don't know, Brad. What do you think?
Yes, I think we're actually highly aligned in that we're trying to help people make better testing and treatment decisions. Right. To me, that's a process. That's a decision process. Okay. You're a role model for how you've navigated that. And what you're proposing to do is to make that available to more people. So what you did as given your advocacy for yourself, how can we make that more available to people that aren't as aggressive as you are, so that we can, basically make that not only available to the 1%, but available to the, who knows, 20%.
Maybe it's the word. Maybe I'll reframe the word, Alan, and you tell me if this lands. But kind of systems thinker maybe is the way to put it.
I like this. Is systems analysis? Is that good? You like that?
Yeah, I don't hate it. It's okay.
Yeah, sounds good. Now, Bill Passman brought up the concept of the tumor board, and I'm going to tell you what my concept of that is. It's sticking in the same room a lot of people that speak different languages that don't normally get in the room together. Okay, we all know Okay. So I'm talking big picture, and now I'm going to get on my soapbox, which everybody's heard, but I want to say it again. It's called the Tower of Babel. You guys are process people. You're trying to figure out what the best processes are to figure out cancer, whether it be delivery to patients who are, whatever the subtopics are. But what you made, the elephant in the room, in my opinion, is everybody speaks a different language. Everybody has a different specialty. So it's I can tell you, in tumor boards, you guys don't go to them regularly. I do. I'm going to make it up. There's arguably 100+ fields in medicine. I get in the room with all these fields, and it's absolutely clear to me they do not speak the same language. I mean, you can imagine an ear, nose, and throat doctor. How much is he going to know about gynecology? When he doesn't see gynecology, he has no experience. All he has is the knowledge base of when he was in medical school and communicating with other people that might have, or recognizing there's a gynecologic problem, and he has to triage them to somewhere else. So yeah, I'm sorry, I'm doing the Tower of Babel situation. So I think really, if you want to make the process work, you have to be able to get not only different languages in the room, but somehow have translators, okay? Because I can tell you, I'm beating my head against the wall here because I'm a pathologist, and nobody speaks pathology, including, like, I asked Dr. Armstrong a question about Gleason 3, and I realized it's a ridiculous question. He's an expert in prostate cancer. He has his own answer, and I know it's a medical oncologist answer, and he has no understanding of the pathology. My question really should be to Jonathan Epstein, who's the guru in prostate cancer. What I'm trying to say is you're going to beat your head against the wall if you really want to get the process done like in a great way, in an optimized way. You're going to beat your head on the wall, just like I beat my head on the wall when I talk to all the second fields in medicine.
Couple of can I jump in with a couple of thoughts and a question for you?
Yeah, go ahead.
What I think I heard is, okay, Tower of Babel, you have many languages, that are incompatible with one another. You're talking past one another.
Yes.
But there's also a very strong element of bias implied by what you're talking about, right? Which is, I'm a gynecologist. I see the world through, well, I won't say what I was going to say, but you know what I'm saying.
That's the bane.
There's bias. You're going to have bias based on training. You're going to have, languages that are incompatible. There's no universal language. Let's just say that everybody can speak. And there's a assumption that the people in the room are the clinicians primarily as the kind of decision makers to assess what the right thing is. So I heard 3 assumptions inside of that, if that's accurate. My question to you, not to lead the witness too much with those assumptions, but I give you a magic wand. What actually is the right solution to getting the best sort of answer?
I know the answer. It's the Amsterdam model, but the Amsterdam model is not possible. Okay.
I don't know what that is.
You guys are talking about there's 4 things. There's established medicine. It's no secret. Everybody can get it. It's in compendiums. There's no secret to that. That's established. Okay. You guys are trying to be on the fence between the fence to the frontier, and I'm going to divide the frontier into immediate, intermediate, and future. I'm telling you, the intermediate to future world, which most cancer patients are not interested in because their window is 6 months to a year, especially GBM and pancreatic cancer patients. The 2 frontier things, and I'll tell you what they are. The 2 frontier things are immunotherapy and precision medicine vis-a-vis targeting the molecular pathways. Those are the 2 things. Those 2 things, the people that speak that language are all have what I call the clinical medicine's basic science divide, which has been astronomical forever, but it's starting to get closer and closer. I'm going to tell you the 2 fields that if you really want to bridge this, the 2 fields are basic molecular biology bridging with molecular pathology. But the crazy thing about that is there's really no molecular pathologist, even though everybody will beg to differ, because it's in its infancy. So yeah, there's molecular pathology departments now in every academic medical center in the country, but they're in their infancy. And I can give you numerous anecdotes of how I know they're in their infancy. And then you have basic molecular biology, a completely different language. I witnessed one guy that started to make it sound like he was bridging it, and that was Michael Castro. And not only was he bridging the two, but he was trying to bridge the two with AI. And AI is a language I know nothing about, but it's clear to me that it's going to really, if you want process pushing, obviously AI is where it's going to be as far as the intermediate and the futuristic.
I have a comment I'd like to make on that. So one of the things, I'm giving a talk on this, in fact, next month.
Yes.
But in terms of the tumor boards, one of the things I'm putting into my tumor boards, in fact, are LLMs. And I go and have a different LLM from different vendors, and each one trained in a different way, and each one has a voice in determining exactly what the next decision is. And that addresses a couple of things. First off, it goes on and addresses scalability, because we don't have to go on and have a bunch of guys with egos in a room to do this stuff. We can balance it out with these other machines that are doing it as well. And the second is that if you have rare capabilities, like you're talking about with respect to molecular pathology, I can still go on and have, again, this is going to take a while to develop, a molecular pathologist on each and every tumor board that these people participate in. So I'd like to throw that out there.
Bill, that's brilliant. Let me just, again, as moderator, it's been 15 minutes. I'd like to get to Brian and hear what his question is.
Yep. Alan, let's take it offline. I want to continue this.
I'm going to make it a little bit more tactical. So, Ari, when you look at, your focus on diagnostics, I had the same inclination when I was diagnosed with prostate cancer, 8 years ago. That what was missing from my care was truly understanding my disease and understanding it from a lot of different angles. So just curious what your experience has been with diagnostics and how you've approached it.
Yeah, I mean, I think what I've realized is how limited my own personal diagnostics. I think the way you framed it is perfect, which is like understanding your disease from many different angles. What became very clear to me in going through my own experience was how kind of myopic the standard of care was looking, a bunch of receptors and maybe a little bit more, do a FISH study, PET. And so, that's great, but the amount of daylight between that and what's actually available outside, like, through if you were to pay an expert to run all the set of possible diagnostics on you and kind of get that concierge model going, like, no doubt you will get more information, some of which may be noise, some of which may be signal to producing a better outcome. But it's very clear to me how limited a blood panel to see what's happening. I go to I went recently to Dana-Farber to talk to my oncologist. So should we be doing liquid biopsy? How, I don't know, what's the new innovations? Because I'm a little bit concerned that the way I found the tumor in the first place was luck. And I maintain that if I was, say, 20 pounds heavier at the time and, running less and whatever, I probably just wouldn't have found this thing. And then it becomes one of those cases of oh yeah, guy dropped dead, out of nowhere. Who knew? And so the advice I'm given from Dana-Farber, which, that's a high trust place, and I trust my doctor, is, every year or 6 months, we'll do some blood panels. And I mean, as well as I do, that don't really pick up all that much, or maybe they will, and you'll get lucky with a white blood count, but there just isn't a lot of meat on that. And so what's out there that might help with detection? Brad and I both have kind of follicular, let's say. And so, he's telling me the tests he's running through Tony Magliano, and I'm like, oh my God, I need to be getting those. And, at this point, I'm fairly educated, and I still feel totally uneducated on the set of tests that are available. I do know that set of tests is rapidly growing in various ways, and the amounts of signal that'll be coming in will be large and ever growing. how actionable it is with respect to the standards of care, big question mark. Probably I wouldn't be super optimistic about fully folding those data points in, but I guess that's my experience is I'm very keen to understand what's out there in terms of the diagnostics based on various condition types. I also know how limited the standard of care actually is, having seen it firsthand.
If you could wave like a magic wand, what would you want from advanced diagnostics?
I think I would want a platform that is delivering what Tony Magliano or somebody like that at scale. Tell me what test I need to run, what data should I be looking at, help me understand how I can be optimizing whatever I'm doing right now such that I don't have to interface with the medical system as much as is humanly possible. Optimize my costs, optimize my outcomes and my health, take advantage of opportunities for diagnostics that are maybe loosely coupled from the medical system, inside the medical system if warranted, and then help me sense make from that data what actually is the right thing for me to do as an individual, as an N of one or whatever. But also do it in a way that I'm not breaking the bank to do this. Like I have friends that are paying thousands of dollars for like a Peter Attia kind of thing. And you're like, oh my God, like this is just out of reach for I mean, it's great, right? Like, sure, I wish I had that, but I mean, that's not me and that's not most people. And so I think it's also leveling the playing field on the data access and interpretation to people that aren't going to be the people like all of us talking. I mean, I think we're all going to speak the same language, have the same sets of dispositions. And that's just not most people, like, nor should it be really, but could you build a platform or a system or whatever to take advantage of a lot of the emerging technologies that, you know, aren't going to be utilized by as many people as they should be to make the best possible decisions and get the best outcomes and cut cost from the system. So it's a bit of a hand wavy answer. I don't know exactly what it should look like tactically, but it'd be roughly something in that strike zone, I think.
Makes sense.
Okay. Last, to close this out, I'll stop recording, but I want to give you, Ari, the final word. Sort of anything you want to say, kind of summing things up here.
Sure. I mean, first off, I'm really honored to be with this group. I think this is really like a group that most people should aspire to be like, who are dealing with these sorts of issues. And it's really, really rare from everything that I've seen. So, I mean, just Brad, like giant kudos to you for like keeping this thing going. I hope that some of these approaches are maybe useful, would be happy to talk about them further. But also as we kick off this accelerator, Brad and I do think there's probably a role, and this is exploratory, for this group, some of the people in this group, depending on, you know, interest, to potentially get involved and help some of the participants in this accelerator to stress test ideas, to, you know, giving ideas of your own based on your own knowledge and insights, which, you know, runs obviously very deep. Looking at you, like Alan, you know, lots of understanding of various parts of this domain that a lot of people just don't have and probably would benefit from in building out solutions to this. So I think that's it for me.